Hello and welcome to Healthy Brain and Mind. I'm Dr. Aaron Menon, and I was initially planning to do a very generic theme for my first video, but given the current media attention on psychiatry in the UK, I thought I'd talk about a more contentious subject, namely restraining patients in hospital environments. As a doctor, it's probably one of the hardest things in psychiatry to see when a patient is acutely disturbed for whatever reason, and in a position where they're quite vulnerable and maybe harm to themselves or to other people, and then nursing staff basically jumping in, restraining them by holding them physically, whilst the patient is trying to get out of the hold or whatever, and then essentially being dragged in a controlled fashion to somewhere a bit safer. Given that most of us, I'd hope, came into medicine or the healthcare profession in general to care for others, it's almost the complete opposite of what we're usually trying to do. Where, as a child, you think of giving people, medication or doing an operation to make them feel better, and then they're all happy again. And we're in this case trying to hold somebody down in a way that they can't move, because they, for example, might be feeling really paranoid in themselves and they feel that somebody is out to get them and they need to act first. There's reasons why we use restraint, and it probably, at this moment in time in 2013, I guess, when I record this, a valid use in our profession. It's usually used where it's usually used as a last resort when people are at risk due to their mental illness, not due to just being naughty, as it were, or just causing a fuss on the ward. It's not for that. It's for use when there is a real risk to somebody or themselves. For example, we may encounter it when somebody, given the same example before, acutely psychotic, quite paranoid, maybe voices, for example, hearing auditory voices, hallucinations, and they're maybe saying that they're, a patient or a staff member is out to get them and is going to harm them in some way, and then they have to act. Naturally, you have to find a way of stopping that happen for the safety of all involved, and it's used in a proportional manner. It's very much a last resort. It's not something that you nurse and staff just jump into, unless there's a precedent for it, and there may be very specific circumstances for that. But generally speaking, it's not something that's used at a whim. It is commonly used, though, because of the nature of some people's mental illness, or the severity of it in particular. There could be other examples. Somebody wishes to leave the ward. That in itself is not a problem. People are allowed to leave the ward. We are a hospital, not a prison, after all, and that's partly why we use restraining techniques, because we don't have locked doors and fences in typical acute settings. But if somebody is, for example, depressed, suicidal, and is wishing to leave the ward, and staff has seen how they are feeling and how they're looking and feeling, and they're actually quite concerned that they might do something that they really would regret if they were feeling better, then there is a need to stop them leaving the ward. In those situations as well, we would be restraining under the Mental Health Act if they're a detained patient, a committed patient, or if they are an informal patient, a voluntary patient on the ward, where they have agreed to come into hospital for treatment and they're now suicidal and wishing to leave, then you have to actually use the legal system, Mental Health Act, to restrain as well. Another example, which is probably the most harrowing observations, is when maybe a young girl with an eating disorder, anorexic, for example, not eating, not drinking, stick thin, very close to death, essentially, because of the illness, is being force fed. And if they're not wanting to eat, you have to again restrain them in a way that they can be force fed. that for me, I mean, I've only seen it a couple of times myself. I've not worked in eating disorders units directly. I've covered it as an on-call doctor, for example, but that's probably one of the hardest things to see. And it provides a lot of guilt, because you're thinking, are we doing the right thing, essentially? And it provides a lot of strain as well on the nursing staff, of course, because they are trying to be caring people as well, seeing these patients 24 hours a day, as opposed to us doctors, building up, almost friendships with them, and then they're having to hold somebody down, force them to drink some sort of supplement, for example, or take medication. So it is a very difficult thing to deal with, even from a professional point of view. From the patient point of view, it must be absolutely terrible, because particularly if there's no insight, if the illness is completely driving their behaviours, they must think essentially that we are the police in a way. We are just holding them down. There's somebody that's going to get me. I'm being stopped by them, or I just want to die. They're stopping me doing it, and it must be a completely traumatizing feeling. Particularly if you remember, actually, because at times when illness is driving things, your concentration's not so good. You maybe hopefully get better in due course, and these memories will fade away, or you can may be able to reflect on it and think, oh, I'm glad they did it in a way, otherwise I'd be dead. But if you're still still struggling emotionally, and then you look back on these things, it really puts a lot of conflicts, I'm sure, in people's minds about what we do, and a lot of conflicts in people's minds about whether what they're doing, what doctors and nurses like ourselves are we doing the right thing for them. In terms of the restraint itself, there's a lot of contention, and there's been media releases today, being the 20th of June 2013, 19th of June, where face-down restraint is still being used in a number of trusts, and there was a list of various trusts, NHS trusts in the UK, that are still using it. Thankfully, I guess, in my 10 or so years in psychiatry, I've not really seen that. I can't recall any event where I've seen somebody having to be face-down specifically. Again, it's hard for me to really give an opinion. That's probably one for nurses in particular, actually, who do the restraint. Would probably give a better opinion about that. But I would probably imagine that it's something that is to be phased out, and I'm aware that there has been some trusts in the NHS that has banned it, and it doesn't, from what I can tell very superficially, there doesn't seem to have been a major problem in terms of being able to deal with agitated patients. The counter-argument to that would be that people should be restrained face down if they are severely agitated, and staff are finding it very difficult to control them on a face-up manner, where they might be kicking out or punching out. Some people can be very strong, and despite using 5-6 people trained in restraint in a controlled fashion, in a safe fashion, people somehow are able to summon up the energy to combat all the staff involved, and again putting themselves in a very vulnerable position, and staff in a vulnerable position. So that might be the counter argument to it, but I would then argue to that we should have either better training for staff so they have the abilities, more staff even, if there's an issue about not having the right amount of staff to be able to do a controlled restraint in a face-up position. Or I guess in the very longer term, make sure we as psychiatrists have the right treatments that can help people get better quicker, so they don't get to a situation where their illness is so severe that they're so agitated that they get into these positions in the first place. But as mentioned before, it is something we do have to do, and it isn't a very pleasant experience for anybody. What will change, I guess, in the future is, I'd like to hope that the face-down method is phased out. Again, it's whether it's not a particularly humane type of way. I mean, again, people might argue that it's a necessity, but I might not be one of those people as such. But people hopefully restraint in general will phase out as psychiatry advances. Either through situations like the environment itself. I mean, I'm sure there must be some correlation of sorts, where the environment of the ward might be such where it gets patients into a situation where they are feeling more vulnerable, either overcrowded wards or just not a very therapeutic environment in general. Maybe as can be the case, some wards can be pretty bare, pretty dreek, using a Scottish word, and people might not feel comfortable in such an environment, and it just makes them more agitated still. But that again is a longer term issue. We need buildings, we need funding essentially in the mental health in general, and that's one for another video. For these things to happen, so that people can feel much more comfortable in themselves, feel like they're being in a safe environment despite any behaviours driven by the illness, and for these restraints to be used rarely rather than more commonly as it is now. But it's a very, very difficult situation. Hopefully, from a medical point of view, from a doctor's point of view, as mentioned, it's obviously very difficult, but we do thankfully understand that it is illness driven. We don't think of the patient involved being a bad person. We know that when they get better, they're like anybody, like we're all, normal human beings. We're all very, generally speaking, very likable people. We don't like everybody in life, of course, but most people we meet in life, thankfully, are reasonable people, and so are the patients that we're restraining, and we know that their behaviours are driven by illness, and we certainly don't. We hope that it's not people's experiences of it aren't such that they feel that they've been punished by it. I think it might feel that at the time, don't get me wrong, and I think it is quite hard at the time when the illness is really, really pushing people's thoughts and behaviours, but I hope that when people reflect back on it, they realise the context of it all. It is, as I say, a last resort measure. We were meant to, quite rightly so, try and de-escalate the situation by speaking to people, trying to understand how they're feeling at the time, what's going on that's getting them to a situation where they're feeling quite tense or anxious or whatever. Try and reason through it, try and work through the thoughts that's going on. Offer medication if it's illness driven. Try and offer medication earlier rather than later, and hopefully that just helps them calm themselves down and get to a position. But as I say, if all these things fail, if the illness is so difficult, or for whatever reason, then restraint has to be used, and then we have to then sadly think about, if it is completely driven by illness, think about whether we need to look at the environment. Is this the right ward for such a patient? Should we be looking at a more secure environment so they can feel a bit safer there? Or whether we need to look at the medication at times. Should we be giving, we still offer oral medication at all points, but if an injection needs to be required to deal with the situation more acutely, so that he or she isn't at risk to themselves or others. But even then, it's there's certain situations where you just maybe restrain, make sure you're able to move the patient to a safe area of the ward, wherever that may be, or even a seclusion room, which are still used in the UK, and let the situation just fizzle out. As long as they're safe, as long as staff are safe, as long as patients are safe, then all is well. You don't necessarily have to medicate. You don't in these kind of situations. If anything, we don't really want to go down that road, and we want to keep things quite regular with any treatment, rather than just doing things as a reactionary measure. I'm speaking from a UK perspective, of course. In other countries things may be different, and sadly in the more developing world countries, because of the resources and the lack of a kind of a reasonable hospital environment for a lot of mental health patients, people are chained to beds and all sorts of things like that. That will hopefully change sooner rather than later. It's obviously it's probably psychiatry is probably the most underdeveloped speciality outside of the developed world, and you hear of fires in psychiatric units, and people, dozens are killed because they're chained to beds and such like. thankfully Britain has moved on from that a long while ago now, and hopefully other places will do the same once they're able to receive the funding that's appropriate for it to move on. Other countries, including developed countries, use straitjackets. It's not something that's used particularly in Europe anyway, that I'm aware of. And it's popular, obviously, in films and the media in general. People think of the crazy man in a straitjacket. Again, it's about proportionality. I mean, if somebody needs a straitjacket, they have to be very, very unwell, in my opinion, to require such a thing. And it's akin to the face down thing. It's a humane thing to do. I'd like to think that there would be, generally speaking, other alternatives to a straitjacket to be used, and hopefully that kind of practice would fizzle out over time if it is still being used. But I hope that has been useful in trying to understand why mental health professionals, psychiatrists and nurses use restraining methods to deal with patients. As I say, there's a lot of media attention on it now, particularly regarding face down, but hopefully it does promote some sort of discussion, like I guess my video regarding the use of restraint in general and how we go about it and how can we move forward from using it at all, because as I reiterate, nobody really wants to use such techniques. It doesn't fit in with our desire to help people. It seems like we are punishing people, and whilst we understand that it's not that, that's certainly not what we're doing, it still kind of niggles in the back of our mind that this is not something we want to do. It feels like we are failing people, essentially, that we're having to get to a position that we're having to hold people down or frog march them from situations. So I'd be glad to hear your comments, either people who have experienced it themselves or people who have not and feel they have an opinion on it. And also it'd be great to hear from those that have seen other techniques being used around the world. If anybody wishes to make any of these comments, please comment in the video itself. I will see you later. If you did enjoy the videos, of course, please like the video or subscribe, and I'll try and do some more content in due course. But for now, goodbye.